Hello and welcome to this presentation for NCEA 2023. This virtual session is athletic training in Catholic schools, and I am your presenter, Mike Hopper. I am the head athletic trainer at Bishop Lynch High School in Dallas, Texas. I am a licensed athletic trainer in the state of Texas and nationally certified by the Board of Certification for Athletic Trainers. I am a CPR instructor through the American Heart Association and an instructor through Stop the Bleed. So we teach CPR and Stop the Bleed courses for our faculty and staff each year. And between the school nurse and myself, we lead these sessions every year. I have a master's degree in pediatric sports medicine from the University of South Florida, Morisani College of Medicine, and a bachelor's degree in health management with an athletic training concentration from Southeast Missouri State University. I've been an athletic trainer since December of 2010 and have been at Bishop Lynch in Dallas since August of 2014. So the 2022-2023 school year, I am finishing my 9th year as the head athletic trainer at Bishop Lynch, where myself and my assistant athletic trainer are responsible for approximately 700 athletes and over 30 sports, ranging anywhere from your normal sports, football, volleyball, basketball, baseball, all the way to crew and boys and girls lacrosse, boys and girls wrestling, and pretty much everything in between. So we provide care, like I said, for 700 athletes every year. And in this presentation, what I want to talk about is what it means to have an athletic trainer and kind of where we are as Catholic schools and athletic training and where we're headed. So I have no financial conflicts of interest. I will say that, obviously I am very passionate about athletic training, and filming this in the month of March, which is National Athletic Training Month. Advocacy is a large part of what I do in our profession, and I believe that advocacy for athletic training is advocacy for sports safety, and so we'll talk about that as we go along through this presentation. So a couple objectives here that we want to talk about in this presentation. First of all, understanding the role of the athletic trainer in the school setting. So we're going to talk about the different domains of athletic training. We're going to talk about the qualifications of an athletic trainer throughout this presentation. And I hope that you are able to understand what our role is, in the school setting, and how we provide healthcare in a school setting, and for us specifically in a Catholic school setting. We want to acknowledge the gaps in athlete safety, and there's been some great research on this that we'll talk about through the Corey Stringer Institute at the University of Connecticut. And I've taken some of that research and made it more particular to Catholic schools, so we'll look at that in a little bit. But again, I want to be able to demonstrate to you how many kids are missing out, and how we have a long way to go in providing the level of care that really is important for our student athletes. And again, I think if you have turned the TV on in the last 2 months, 3 months, you've seen what that looks like as Damar Hamlin collapsed on the football field on Monday Night Football. I think a lot of people had their eyes wide open when that happened, and I know that our school administration has, as some of those stories have come out, and we feel like we're a long way ahead of the curve in a lot of things, but there's always room for improvement, and we'll talk about some of these gaps in athlete safety. And then lastly, we're going to recognize best practices in athlete safety. And I think a lot of people talk about practicing at the top and advancing in everything that we do. And in sports safety, best practices keep us out of lawsuits, keep us from losing lawsuits. Let me rephrase it that way. And so I think it's really important that we start considering and understanding what best practices is, so that we can help to mitigate liability. And I think that's a really big key that we do as athletic trainers, is mitigate liability, for not only ourselves, but also our coaches and our schools. So first off, we're going to understand the role of the athletic trainer, and let's look at some educational qualifications. Athletic trainers must be a graduate of a CATI accredited program. CATI is the Commission on the Accreditation of Athletic Training Education. So this organization sets the standard of what must be taught to a prospective athletic trainer while they are in college. And athletic training education has changed quite a bit over the last 30 years or so, and recently just made a major change in that the CATI accredited programs have now moved from a bachelor's level program into a master's level program. And literally we're talking last spring, that final transition has happened. So pretty much anybody now that are graduating are going to be graduating with a master's degree. This allows them to sit for the board of certification exam, which is a national certification exam that is recognized by 48 states. Actually, it's recognized by 49, California being the only one that is not. But in 48 states, you must be a certified athletic trainer through the board of certification in order to practice athletic training in that state. Like I said, California is an outlier. California does not require any type of regulation of athletic trainers whatsoever. I am going to leave it at that because my time is limited. The state of Texas is the other state that does things a little bit differently. The state of Texas has its own apprenticeship program that can lead to somebody taking the licensure exam in the state of Texas and becoming a licensed athletic trainer in the state of Texas without being a certified athletic trainer. But in the big picture, in the general picture here, when we talk about athletic trainers, we talk about certified athletic trainers. And again, that's through the board of certification. Also, like I said, I just mentioned licensure or other form of regulation. There are a few states that use the term registered athletic trainer, although I think most of those have gone away, or certified athletic trainer still, rather than licensed athletic trainer. But for our purposes today, it's all the same. Okay, every state has a little bit different as it relates to regulations on athletic trainers, as it relates to scope of practice and what an athletic trainer is or isn't allowed to do. But for the most part, what we're going to talk about here today is pretty much across the board, across the country. Okay. So like I said, and even before they went to a master's program, over 70% of athletic trainers did have a master's degree in something. So it's not unusual. And like I said, I have a master's degree, what's considered a post-professional master's degree. A lot of people have had master's degrees for a long time. Now that's just the minimum standard. Okay. So in athletic training, we talk about 5 domains of athletic training, and we're going to talk about each one of these individually. The domain number 1 is injury and illness prevention and wellness promotion. Domain number 2 is examination, assessment, and diagnosis. Domain number 3 is immediate and emergency care. Domain number 4 is therapeutic intervention. And domain number 5 is healthcare administration and professional responsibility. And we'll talk about each one of these individually here in a minute. But athletic training is unique in healthcare in that so much of healthcare is reactionary, especially here in the United States. Healthcare is reactionary, and we only deal with something after the fact, right? And so athletic training is really unique in that we're there before the injury happens. We're often there when the injury happens, and we're there after the injury happens, right? And then we're there throughout the entire process from the time of the injury through the rehab process and back to return to play. And that's why athletic trainers do what we do, is we love getting to watch our athletes return to the floor, return to the football field, whatever the case may be, and return to the sport that they love. But we also like to prevent those injuries in the first place, and make less work for us as it is. Okay. So domain number 1 is injury and illness prevention and wellness promotion. And we do this in a lot of ways. One of the things that I think sometimes athletic trainers don't like to look at or don't like to think about, but we are really well known for taping ankles, right? Or taping wrists. And the reality is that's not all we do, but it is something that we do a lot of. So taping and bracing. And like I said, taping ankles, taping wrists, but also bracing. Ankle braces, elbow braces, knee braces. You'll see, if you saw a picture of our offensive line at Bishop Lynch, every single one of our offensive linemen on our varsity football team, they wear bilateral knee braces, just like you see at the college level. Okay. And ultimately, I become responsible for fitting those and maintaining those braces. The number of injuries that we've had in an offensive lineman who was wearing knee braces, I can count on one hand in 9 years. All right. But I can also tell you that I've seen multiple knee injuries in linemen who didn't have knee braces on. And so it's a controversial topic, whether to knee brace or not, and it is an expensive topic. But we found it to be important. And so that's one of the things that we do as a way to prevent injury in the first place or mitigate that injury. Okay. We demonstrate stretching, right? Different stretches, and we work through different stretches and mobility exercises and things like that. Strengthening, we'll do a lot of strengthening in our rehab processes. In some schools, the athletic trainer also doubles as the strength conditioning coach. We're lucky at Bishop Lynch to have 2 full-time strength conditioning coaches on staff. So that's not a role that we play as athletic trainers at Bishop Lynch. However, we do have discussions with our strength conditioning coaches, and we are somewhat involved in that strengthening process. Working together on the athletic performance side of things. And then we also sometimes get tasked with nutrition and hydration. Obviously, you see athletic trainers all the time with Gatorade bottles and Gatorade coolers and things like that. And so sometimes hydration is a role that we play. And we also get to have lots of discussions about hydration and sometimes nutrition. In a lot of places, the athletic trainer wears a lot of different hats, and those hats vary based on the location and the different school environments. Domain number 2 is examination, assessment, and diagnosis. So we evaluate injuries, whether it's on the field, whether it's on the court, in the athletic training room, in the nurse's office. We evaluate injuries, whether it's orthopedics, sometimes gen med, sometimes concussion. So, really athletic trainers, we do a lot with orthopedic injuries, that sprained ankle, that ACL tear, that muscle strain, those sorts of things. And again, we evaluate those right on the field. We also are typically considered to be the expert in concussion management at the high school level. We play the role of liaison. between the school and the doctor's offices when it comes to concussions, but also, again, we do a lot of clinical diagnoses with concussions on the field or in the athletic training room on a somewhat regular basis. And then we do some general medical evaluation, and again, it depends on your individual setting. In our particular setting at Bishop Lynch, we work really closely with our school nurse. And so we tend to deal with the orthopedic or concussion issues that she has presented to her. In exchange, we send her the general medical stuff that comes to our door. But especially over the last 3 years with COVID-19, we have had to play a much larger role in the general medical process and helping our school nurse over 2+ years, at the heart of COVID. But not just here, but across the country, athletic trainers became really good at doing COVID testing. And so that's another thing in the process that we did in order to get sports going again and to keep jobs, right? Athletic trainers found themselves in hospitals and clinics working along other medical professionals in roles that we didn't typically play, but it became necessary during the pandemic for us to do so. And so I think we've all learned some new valuable skills in the world of general medical evaluation along the way. But again, we're fortunate here that we don't have to deal with a lot of that, and we're able to let our school nurse deal with that. And that's a healthy relationship that we have between the athletic training room and the nurse's office and our staffs that are not as common around the country. But we work hand in hand to provide care for over 1,000 friars on a daily basis. And so it's really important that the three of us work closely together in that process. But again, examination, assessment, and diagnosis. There was a study a few years ago that came out, and it pops up every now and then that orthopedic surgeons agreed with the evaluation and assessment that an athletic trainer had provided approximately 92% of the time in this particular study. And so you look at that, and we look at that as a very favorable thing, because we're making decisions and we're making assessments on the field or on the court. We don't have X-ray, we don't have MRI, we don't have CT scans, whatever it is, we don't have that available to us. It's what are we able to determine based on our hands-on evaluation. And so I think for 92% of those evaluations to be agreeable between the athletic trainer and the orthopedic surgeon is a really promising number, I think, for us. And it can also be beneficial when we talk about a concept known as AT value, which I've become a very big advocate for and a leading speaker on over the last few years across the country. We're saving a lot of money when we can actually make this assessment and evaluation and not have to refer somebody to a physician for some of the more minor injuries that we're able to manage in-house. Okay. Again, January 2nd, everybody saw this on Monday Night Football. Immediate emergency care of an injured athlete. And in this particular picture, you see this is myself and our staff. My assistant is in the picture. Our team physician is in the picture. And as well as EMS staff, we are spine boarding this athlete or a spinal motion restriction we'll talk about in a second. This athlete ended up being fine and ended up playing the next week. However, we needed to take precautionary measures to rule out some sort of spinal cord or brain injury. Okay. I've mentioned it, January 2nd. Athletic trainers are trained in CPR and AED use. Again, Monday Night Football, everybody saw it. The assistant athletic trainer for the Buffalo Bills started CPR within 20 seconds. He recognized there was a problem. He recognized there was no pulse. There was no breathing. He started CPR within 20 seconds. The athlete was shocked with an AED. He received CPR for approximately 9 minutes on the field before being transported to the hospital and has been released from the hospital since then. And that's an amazing feat. But it demonstrates, and this happens around the country in American schools. Cardiac arrest happens once every 3 days. So you're looking at several thousand cardiac arrests every single year. And the athletic trainer, along with a school nurse, provides a level of care that in a sudden cardiac arrest case, there's research that demonstrates that normally sudden cardiac arrest outside of a hospital has an approximately a 7% survival rate. And when there's an athletic trainer present and there's an AED present, that number goes from 7% to 90% survival rate. Most athletic trainers hope they never have to use this skill in their entire career. A lot of athletic trainers never do use this skill in their entire career. But as somebody who has done it on our campus, it is a skill, it is an event that I hope I never have to do ever again. Once was enough in my career, but that one time and some of these other instances has made it that much more important to me. And so cardiac arrest and CPR training is something that I take very seriously and I'm very passionate about. I teach it approximately 5 or 6 times a year. And like I said, I just think it's super, super important that we teach others to do this, but it's also really important that the athletic trainer be there to be able to do so and utilize the skills that we have in a life or death situation. All right. Some of the other things you may see, and again, this is something you see not necessarily a lot, but something that I think sticks out a little more is this concept of what we know as spinal motion restriction. You see spine boarding the athlete. That's a term that we used to use. We've started to move away from that terminology. That's beyond this talk. But basically what we're doing here is if we are concerned about a possible cervical spine injury or a possible concussion, serious concussion or brain bleed or other head or neck trauma, then we would take these precautions where we are stabilizing and restricting the motion of their head or neck. We put them onto the spine board and transported them to the hospital that way. Okay. And then the last thing that you see from an emergency care perspective is splinting of orthopedic injuries. Obviously, injuries happen in athletics all the time. And so we use what are known as vacuum splints. And what these do, these vacuum splints have pellets, little like foam pellets in them. They make quite a mess if you pop one of these. I'll just tell you that from personal experience. But what they do is these pellets sit inside of the wrap or the splint. And when we put this on a body part, what we do is then we will suck the air out of the splint, and it causes those foam pellets to form around the body part without putting a lot of pressure on the limb itself, right? So if we have a broken ankle, let's say, we'll talk about a tib-fib fracture where the two bones in your lower leg are broken, and I've seen this injury a handful of times in my career. We used to use what we refer to as air splints, where we did just the opposite. We sucked air in and it formed around the splint. Well, what happened was that it moved the broken bones, right? The parts, the broken bones, it moved them around. it's extremely painful. So these vacuum splints, and I don't know how long they've been on the market. They've been on the market for a long time, before I got into the profession. They do just the opposite. They suck that air out and it forms around it, but it does not apply pressure to the broken bones at all. It's actually relatively comfortable, in my opinion. But you'll see us do that. You'll also see us use SAM splints for some of our more minor fractures, such as a wrist fracture or a hand fracture. That we can utilize. And the nice thing about the SAM splints is they're relatively inexpensive. They're like $6 or $8 a piece. These vacuum splints range anywhere from 120 to about $400 a piece. So they're significantly more expensive. I know a lot of athletic trainers actually don't carry vacuum splints and just assume that if they're going to need that, they're calling an ambulance anyway. But we do carry vacuum splints. We've used them a handful of times. Fortunately for us, we've gotten them back from the ER each time, so we're not out the $300 or $400 that they cost. And I know that's a major concern for a lot of athletic trainers is losing them in that manner, or them getting destroyed. So, but you see us, in an emergency situation, you'll see us splint this type of an injury and then provide or refer them to further care from there. After the injury happens comes what most athletic trainers find to be the fun part, the therapeutic intervention. And this is our rehab. Okay. So we break rehab up really into about 3 categories: therapeutic exercise, therapeutic modalities, and manual therapy. So therapeutic exercise is as basic as helping them to move through a plane of motion in passive range of motion, active range of motion, where they are completing the movement themselves. And then we start doing strengthening, whether it's using TheraBands, which are big rubber bands essentially, body weight exercises, kettlebells, dumbbells, those sorts of things. And then we get into sport-specific activities and agility drills and things like that to get an athlete back onto the field of play, onto the basketball court, whatever it might be. The difference between us and physical therapists a lot of the times is that the athletic trainer understands the more of the sport-specific movements that are necessary, that a physical therapist may not understand so much. And so we'll incorporate more sport-specific activities into rehab than what you might see in a physical therapy clinic. Therapeutic modalities. We do sometimes utilize ultrasound, therapeutic ultrasound. Not a lot of great research on that. So a lot of clinicians, both physical therapists and athletic trainers, have kind of shifted away from ultrasound. E-stim or electrical stimulation comes in a few different forms, but basically it's electricity that is being sent to your muscle, and we use that for a few different things. We use that for pain control sometimes, but we also will use that for muscle re-education, like after surgery, and help to retrain the brain and the body part how to move. Okay. Obviously everybody, I think, sees ice used in athletics quite a bit. We use ice in several different capacities, whether it's a bag of ice, ice massage. We have units called game ready machines, which are ice and compression. They're really, really cool. And we find so much benefit from them, especially with our post-op patients, with our ACL surgeries and those sorts of patients. And then we have compression, whether again in our game ready units or in the use of intermittent compression. Many people probably know it as a Normatec unit. We have a unit called Air Relax unit, same idea. basically it starts compression at like the bottom of the body part. So if we're doing our legs, it starts at the toes and it's segmented all the way up to like our mid thigh. And then it releases all that air and it repeats itself. And it does that for a period of time. Ours is set for 15 minutes a piece. But we use compression quite a bit. Other modalities I don't have listed here that we utilize is blood flow restriction, which is a fairly newer modality, especially at the high school level. For a long time, BFR was extremely expensive. There are some more affordable options available now, and so you're starting to see more BFR making its way into the high school athletic training room than you saw before. The gold standard unit is about a $5,000 unit, and our particular BFR unit that we have at BL is about a $400 unit, I think. So it's a huge difference, but we get great results from it. And so, like I said, it's more affordable now than it used to be. And then the other thing that we do a lot of at BL is we do a lot of manual therapy. And manual therapy comes in a lot of different ways, a lot of different formats, whether it's simply using our hands, using instruments. We use metal instruments. You may have heard of Graston technique before. I am trained in Graston technique, but we don't use that specific thing. We also do a lot of foam rolling, a lot of lacrosse balls. And then we also utilize cupping, which is, again, relatively new for us. However, it's old Chinese medicine. Many of you saw cupping with the Olympics with Michael Phelps, painting the circles on his shoulder and whatnot. But for us at BL, we do a lot of manual therapy and a lot of therapeutic exercise. We have modalities to use. However, we choose not to use them a lot, and I think that's clinician preference, and that's kind of how we operate. The last domain that we're going to talk about is healthcare administration and professional responsibility. I said earlier on, athletic trainers can mitigate liability for a school in a really big way. We do this through injury documentation. We do this in treatment documentation. Every kid that walks into our door and gets much more than a Band-Aid signs in. And then that is transferred into rank 1, which is our electronic medical record system that we use. And all of that is documented. I can throw all of that into a spreadsheet. And I get to find lots of great details about that our administration really love to hear. Or they just make fun of me for it. It's okay too. We also are responsible for pre-participation exams and making sure that athletes are cleared by a physician prior to starting athletics. Really critical component, making sure it's safe for them to participate in sports. And then we also are responsible for emergency action plans. And so not only do we perform the actions, but we write these documents and we prepare for these documents. Because in the case of DeMar Hamlin, everything that happened from the moment he hit the ground until the moment he reached the University of Cincinnati Hospital is choreographed, rehearsed, and practiced. And every bit of it. And there's a reason it went the way that it did. Okay. And that's emergency action plans. And all of our schools need to have these. And we can certainly do better in that as we go. And then the other professional responsibility that we have is continuing education and continuing to get better. Just like all of you are viewing this webinar through NCEA, athletic trainers have to continue to get better at what we do. In this particular picture, you see I'm actually teaching a lesson, a lab lecture on equipment at a meeting last summer. And then we also practiced equipment removal for football, lacrosse, and ice hockey. So let's acknowledge some gaps in athlete safety. So a great study out of the Corey Stringer Institute, the University of Connecticut, known as the Atlas study, or athletic trainer location and services. What we know from that is approximately 35% of schools employ a full-time athletic trainer. There's over 21,000 schools in America, high schools in America, and 35% employ a full-time athletic trainer. 31% employ somebody in some sort of a part-time capacity, and that means that 34% have nobody. Okay. Now, Atlas broke this up: public school, private school. So what you see here on the left is everybody in the big picture overall. Here on the right, you see private schools. I do not know the exact percentages for public schools. I do know it's 37% have a full-time athletic trainer. I don't know the other two off the top of my head. But in the private school world, 27% have a full-time athletic trainer, 28% have a part-time athletic trainer, and I am not a math student because 45% have nobody and not 55%. But like I said, I'm not a math student. So where do Catholic schools fall? And that's what I wanted to know, and that's what I wanted to be able to tell y'all today. Okay. 2019, I started a project in conjunction with KSI and Atlas to determine that. And the first thing I had to do was determine who Catholic schools were. And at last check, there's a little under 1,100 Catholic high schools in America. And in this 2019 data, what we found is that 41% had a full-time athletic trainer, 36% had some sort of part-time athletic trainer, and 23% had none. Now, I've redone that research since then, and in 2023, we are now at 49% of schools having a full-time athletic trainer, which is awesome to think about. The number of athletic training, or a number of schools that went from a part-time athletic trainer to a full-time position. And I applaud every single one of you, okay? What you do see in this data is that 21% have a part-time athletic trainer, and unfortunately 30% now have nobody. Some of that is because of COVID-19, I think. There are some other factors that are involved in that. But overall, we saw an increase in the number of athletic trainers in Catholic schools in America, which is fantastic. And I think everybody should be applauded for that. However, we do have work to be done, right? With 30% not having any access to an athletic trainer, we certainly have work to be done. So that's where Catholic schools fall. Now, lastly, we're going to talk about best practices. Obviously, I've already said best practices having an athletic trainer at all. But also having an appropriate number of athletic trainers also is important. Okay. Collaboration with the school nursing staff. Working in silos doesn't work. I'll say that again. Working in silos doesn't work. The athletic trainer and the school nurse need to work together closely. And I think that's such an important topic, and it's such a focus of what we do. It's actually amazing to watch kids not understand that we collaborate so closely when they walk into our room and we ask them why they went to the nurse, because we saw it on the nurse's log, right? And they can't believe that we know that information. But we collaborate on a daily basis. Emergency action plans. If you don't have one, you will lose a lawsuit, and I'm just going to leave it at that. You will lose a lawsuit because not having an EAP is grounds for negligence, and you're not going to win. And not only having an emergency action plan, but actually dispersing it and providing it to your staff and practicing it and executing it is super important. And unfortunately, there is a Catholic school who recently settled a lawsuit related to a death where the EAP was a major focal point of problems. And then rehab services. Best practices, be able to provide those on care, on site. We do approximately $330,000 to $350,000 in rehab services on our campus every single year. And Yeah, I think as a private school, that's really important for us to think about where those dollars are going. If those dollars from our parents are going to the PT clinics and to the doctor's offices, then they may not be coming to us in the form of tuition. And that's how I word that sometimes. And so it's really important that we think about that. Rehab services we can do so much with. So as I wrap up here, because we're about out of time, if you want to contact me, feel free to email me. My school email, mike.hopper@bishoplynch.org. If you want to be bombarded by athletic training on Twitter, feel free. My personal Twitter handle is right there. You can also find my personal Twitter handle by using the hashtag AT4All. And then lastly, my school Twitter handle, our Twitter handle for Friars Athletic Training, Friars AT. So we do ask that you fill out the session evaluation survey in the app. And for those of you who are in Irving for NCEA, I hope you enjoyed Texas. Welcome to Texas. For those of you online, I hope that you enjoy all of your sessions. I hope you found this enjoyable. Again, if you have questions, feel free to hit me up. I am happy to talk athletic training, probably more than you ever would want to do so. But I'm also happy to help with any types of resources that might be needed that can help you provide a better level of health and safety for your students. Thank you for your time. And again, if you have questions, please let me know.